My name is Leo Anthony Celi. I'm a data scientist with the Laboratory of Computational Physiology, and that's under the Institute for Medical Engineering and Science. And I'm also a physician. I work in the intensive care unit at Beth Israel Deaconess Hospital. I was born and raised in the Philippines. I finished medical school there and moved to the United States to do my residency and fellowship training. And then for a short period of time, went into industry and joined a startup company out of Johns Hopkins University. And then packed my bags, moved to New Zealand, worked there as a doctor, and then came back to Boston, enrolled in a master's degree program in biomedical informatics at MIT, as well as in public health at Harvard University. And I've stayed in Boston since I finished school. What lured me to biomedical informatics is the frustration that even in the 21st century, the doctors are still doing a lot of guessing in terms of what to suggest with diagnostic tests and treatments for patients. Most of what we do is based on population studies where they study a heterogeneous group of patients, and you try to come up with an average effect for the whole population. And it's really very difficult to apply that to every single patient, which is very different from the patient before. And that frustrated me that most of the time the decisions are based on personal knowledge as well as biases. And as a result of that, we're seeing a lot of variation in care. And at the same time, what was happening when I was doing my informatics is that there is a push for the move towards electronic health records. And to me, that was a big opportunity to leverage the value of data and see if that could help us as doctors provide more individualized recommendations in terms of diagnostic tests and treatments. The very first study that I undertook as part of my master's was just trying to predict how much fluids a patient is going to need when he presents to the hospital with a very low blood pressure. Most of the time we do this almost via trial and error, give him some volume of fluid and see how the patient responds. And if there is some delay in the way you resuscitate a patient, that could mean that the patient gets sicker. And if you give too much, you also get into complications. And basically, we just look back and see whether, even from the time that they came in, we could calculate how much fluids they were going to need for the next 24 hours and try to give that as fast as we could. MIMIC is a database that archives data being obtained from intensive care unit patients admitted to Beth Israel Deaconess. The data has been collected since 2001, and the most innovative thing about MIMIC is that when the group decided to release this, there was a decision to make this open access to the public. And what that entailed is removing all protected health information to make sure that a patient won't be re-identified in the process of interrogating the database. Making the database open access allowed investigators from around the world to ask questions that they have, and the open access nature of the database to allow different groups to ask the same questions and then compare their findings with each other, allow them to critique and cross-validate each other's finding. And we think that this could be a way of addressing the biggest problem that we're encountering right now, which is the lack of reproducibility with biomedical research.